Thank you very much for the invitation to come here. It's a pleasure. And I enjoyed the previous talk. And I also have I read your paper this morning, which was very interesting. And the only sort of sad thing about it is that we talked about that this morning. We could have written it ourselves. Just different references, but the same mission, the same statement, the same thing. It's a very good paper of the overview of the current status in the research field in low back pain. I think it covers it very, very nicely. So, back to my talk. I've sort of looked at Paulo's and Jørgen's instructions for this. I'm not going to repeat this. This is what Paulo presented this morning. And I'm going to have organized a talk around these issues, I think. A lot of what I'm talking about is based on the European guidelines for prevention of low back pain. Been working on those for years, and they're presented this fall. And you find them on www.backpaineurope.org. You can download them there. There you will also find guidelines for acute low back pain and also for chronic low back pain. You will be exposed to backpaineurope.org over and over again. Do not panic. There's been a lot of people involved in this. These are some of the authors. There's also been other contributors sort of reading through the guidelines. And and you find that. I think you're putting the PowerPoint presentations out. Yeah, so you can find it there. So what is low back pain? I'm going to spend some time on the definitions because also the sound question of can low back pain be prevented? Then what are we talking about then? We have to know that first. So low back pain in these guidelines is defined as pain and discomfort localized below the costal margin and above inferior gluteal folds, with or without leg pain. These are subjective pains, subjective complaints. These are pain. We have also been dealing mostly with non-specific or common low back pain because that is the main problem. That's what we're talking about. This is the main reason for sickness leave, and this is the main reason for disability pension. And these are pain that is not attributed to recognizable, known specific pathology. So that is excluded for these guidelines. When we're talking about acute low back pain, normally this is defined as a duration of an episode of low back pain that persists for less than 6 weeks. Then talk about subacute low back pain, normally from 6 to 12 weeks, and chronic low back pain as low back pain persisting for 12 weeks or more. This might be useful definitions, and especially when you're talking about clinical settings. In a clinical situation, this is useful. It's not really helpful when you're considering the matter of prevention, where you see that, as Johan showed, that back pain and its consequences tend to occur in an episodic manner. This varies. In these guidelines, the recommendations concerning common low back pain, they cover both episodic and persistent symptoms. And here, recurrent low back pain is defined as a new episode after a symptom-free period. So you have pain, do not have pain, and then you have pain again. Also that Johan showed in some of his cohort data. People move in and out. It's not a constant thing to have back pain. So the first sound question is it possible to keep the notion of primary prevention for the condition low back pain disorder due to the large prevalence and lifelong incidence in all population? No or yes? Again, depends on the definition of primary prevention. We spent quite a number of meetings discussing this when we developed the guidelines. And when we say that overall non-specific low back pain, it is important, not so much for its existence, but for the consequences. So if you're talking about primary prevention to prevent an episode of low back pain, it's a waste of money, it's a waste of time, and it's not possible to prevent. You shouldn't spend time on it. You shouldn't even think about it. It's not possible on a general level. But the consequences, that's the important thing. So these guidelines consider the consequence of common low back pain to be a primary concern for prevention. There you can do a lot. or at least we think we can do a lot. The consequences of low back pain, these are important from the individual perspective. It's important for disability. It's important for a societal perspective. These are huge economic costs for society. And the consequences include broad issues such as recurrence, work loss, care seeking, health-related quality of life, and compensation. And we could probably add a lot more to it. So again, so sum up that, the general nature and course of commonly experienced low back pain means that there is limited scope for preventing its incidence, for preventing its first-time onset. And prevention should be focused on reduction of the impact and consequences of low back pain. So, sound question number 2. Do we have evidence of a substantial number of chronic low back pain disorders being caused by work exposure? The answer to that is nope, we don't. There is no evidence that show that work exposure causes low back pain. There are risk factors. As also Johan showed, they're not very high, they're not very strong, they vary, but there are risk factors where there is no causal mechanism. So the primary causative mechanisms remain largely undetermined. We do not know, and those we know are weak. So risk factor modification is another point, that risk factor modification will not necessarily achieve prevention. Even if you now target the risk factors we know, which has odds ratio, the strongest one, 2.2, 2.4 that you showed. Even if you target those and do something about them, this will not necessarily achieve prevention. There is considerable scope in principle for prevention, again, on the consequences of low back pain, especially on pain, care seeking, disability, and work loss. If you're looking at these guidelines, interventions that are essentially treatments in a clinical environment. Workers that they sort of, one time of life you are a worker and you are at your job. And then you go on sickness leave. Then you're out of job. Then you're in a clinical setting. And then it's the sort of combination here. So intervention in the clinical environment focused on management of current symptoms are not considered prevention in these guidelines. So of course, we have a lot of things we can do in a clinical setting to get people back to work. That's not covered here. The sound question number 3 was this: if yes, how should the German prevention campaign focus? Since I said no to that, I'm still going to cover it. So what are the best effect measures to evaluate the effectiveness of the campaign? So even if there are no documentation that work-related factors do cause low back pain, there are things you can do to prevent the consequences of low back pain. In general, the bad news, the overall conclusion from this guideline, there is limited robust evidence for many aspects of the prevention of low back pain. There are no very strong documentation. And the main reason for that is that the research has not been done. Even if there's been a lot of research covered on musculoskeletal pain, low back pain for the last 20, 30 years, we still do not have the full documentation. Even so, even if these are so bad news, there is evidence suggesting that prevention of various consequences of low back pain is feasible. However, for those interventions where there is acceptable evidence, and there are some, and I'll show them to you later, the effect sizes are rather modest. So even if you know that this intervention will prevent the consequences of low back pain, it's not going to give you very strong effects, unfortunately. The most promising approaches seems to involve physical activity, exercise, and appropriate education. Then comes, of course, later a huge debate: what is appropriate education? And I will get back to that. However, there is no single intervention that's likely to be effective in preventing the overall problem of low back pain. owing to the enormous multidimensional nature. Prevention of low back pain is a personal issue, but it's also a societal concern. So if you're going to have an optimal programs on the prevention of low back pain, we have to have a culture shift, and I think you have started that debate in Denmark. I was a bit surprised hearing that your paper had caused so much discussions. We are past that, I think, in Norway. And I think they passed that in the UK. Some years ago, they're a bit behind. So I'm a bit surprised. However, you still need this culture shift, and even more so here, I think. How low back pain is viewed, its relationship with work and activity, how it might best be tackled, and what is reasonable to expect from preventive strategies. We should not expect too much. But you should still read the guideline. There is likely to be benefit from getting all the players on site. Again, supporting by Johan's presentation. But we have to have studies so we can understand better the mechanisms and delivery of prevention strategies in low back pain. What is really going on? When a person comes to the doctor and get the correct advices, as we see now, go back home and then open one of these magazines you find all over the place. It says, go to bed, be careful, do not lift, do not twist. What do you do then? Do you trust the doctor or do you trust the magazine? So we have some work to do. And one important point, even if you find individuals that find that various strategies work for them, and you always find it, I have to go to my chiropractor, I have to go and do my specific exercises. I can't lift, right? You meet these people all the time. Even if you have people that find that such strategies work for them, in the absence of scientific evidence, that does not mean that they can be generally recommended for prevention. And also, another important thing, it is not known whether some of these strategies actually have disadvantages, long-term effect. So the recommendations in these guidelines is based on systematic reviews. They're based on existing evidence-based guidelines and scientific studies. And if you go into the literature, you find that the quality of the studies vary enormously. There are enormous amount of studies, but the quality is very varied. And one interesting thing also is that they're very often very imprecise in specifying what type of intervention they've been doing. So we have intervened to prevent low back pain. Well, what was the content of the intervention? It's almost impossible to find out. And it's also even more surprising, you don't really know the outcome. Is it pain? Is it sickness leave? Is it function? Is it disability? Very often you can't really find that out from the paper. It's sort of an overall statement on low back pain, but you really don't know what it is about. So it's not always possible to state exactly which outcomes will be influenced by a given intervention, and there need to be more work done on that. We have graded these guidelines in a level of evidence. Level A is where you have generally consistent findings provided by a systematic review of multiple randomized controlled trials. So there's strong evidence. Level B is where you have consistent findings provided by a systematic review of multiple weaker scientific studies. Level C is a very interesting one because it's either that you have one randomized controlled trials or you have weaker scientific studies or you have inconsistent findings provided by systematic review. And level D is where you have no randomized controlled trials or no weaker scientific studies. There are actually no data to support. The weaker scientific studies is when you have non-randomized controlled trials, before-after studies, interrupted time series, and longitudinal epidemiological studies. And also important in these levels, these are the grading of the evidence. It's not the strength or the effect size. Okay. So, what do we recommend? I divide that into two. So, section 1 is on the general population level, and also then on workers. These overlap, and it's they have you can, and many of the recommendations are quite similar. So, for the general population, we find that physical exercise is recommended for prevention of sick leave, is specific, due to low back pain, and for the occurrence and duration of further episodes. And this is a level A evidence. However, there is insufficient consistent evidence to recommend for or against any specific type or intensity of exercise. So this is sort of whatever you do, just do it. And I think, Holly, I'm going to give one of your points away, I think, which I think you will say, and you can repeat it later, is that the thing they find in their guidelines is that there should be equal, whatever exercise the therapist and the patient agrees upon is the good one, is the one you should go for. So, we might find later that there are specific types of exercises that are better than others, but at this stage we do not know. We can't recommend for or against. Then information and education about back problems, if this is based on the biopsychosocial principles, that's important, should be considered. However, information and education focus primarily on a biomedical or biomechanical model cannot be recommended. And I guess this also gets into the Danish discussion, I have a feeling of. We passed this discussion in Norway, and also I think most of Europe. So this is important. It's the biopsychosocial principles that are important, not the biomedical, not the biomechanical. Then back schools, when they're based on traditional biomedical, biomechanical information, advice, and instruction, are not recommended for prevention of low back pain. And this is a level A evidence. These are strong evidence. They're not recommended. However, high-intensity programs, which comprise both an educational or skill program and exercises, can be recommended for patients with recurrent and persistent back pain. With recurrent and persistent back pain, so the consequences. Further, sort of following in the same line, lumbar supports or back belts are not recommended. Strong evidence. There is no robust evidence for or against recommending for any specific chair or mattress for prevention of low back pain. However, there are some data, one study showing that persisting symptoms may be reduced with a medium firm rather than a hard mattress. This created controversies in Norway. I had numbers of emails from the industry producing, beds, chairs, etc. Our chair, this might prevent. And they all want to do randomized controlled trials to show their effect. And I never heard from them after that. Okay. There is no evidence to support recommending manipulative treatment for prevention of low back pain. I've heard, I don't know how it is in Denmark. I know in Germany there's increasing propaganda to recommend for manipulation to prevent low back pain. It started sort of in Norway, but there is no evidence supporting that. Shoe insoles are not recommended in the prevention of back problems, and there is insufficient evidence to recommend for or against correction of leg length. So, going over to the workers, do they vary very much from this? No, not very much. Again, number one, the strongest recommendation is that physical exercise is recommended in the prevention of low back pain. It's recommended for prevention of recurrence of low back pain and for prevention and recurrence of sick leave due to low back pain. One of the few places where the outcome has been specified in enough studies so we can draw this conclusion. Again, there is insufficient evidence to recommend for or against any specific type of exercise. So just go and do your work. Similar again, back schools based on traditional biomechanical, biomedical information, advice, and instruction how to lift and bend are not recommended for prevention of low back pain. There is insufficient evidence to recommend for or against psychosocial information delivered at the work site. But there are promising data coming. But information oriented toward promoting activity and improving coping may promote a positive shift in the beliefs. That's only one RCT showing that. Again, also as in the general population at the work site, lumbar support or back belts are not recommended. Shoe inserts or orthoses are not recommended. And there is insufficient evidence to recommend for or against insoles, soft shoes, soft flooring, anti-fatigue mats, etc. The studies has not been done. On the ergonomic recommendations, as you have understood, there are very few recommendations there. However, temporary modified work and ergonomic workplace adaptation can be recommended to facilitate return to work after sick leave due to low back pain. So not as a prevention to begin with, but if you have been out of work and you're returning to work, you might consider ergonomic adaptations. That's a level B, so it's not very strong. There's insufficient consistent evidence to recommend physical ergonomics interventions alone for prevention of low back pain. The data are inconsistent. The RCTs has not been done. The relationships between ergonomics and low back pain is mostly from epidemiological studies and very little on a randomized controlled trial. However, there is moderate evidence that a successful physical ergonomics program must include an organizational dimension and involvement of the workers. So the workers must want what you're trying to sell them. There is insufficient evidence to specify the precise useful content in such interventions. Again, it's not well enough described, and it has not been done enough studies. There is insufficient consistent evidence to recommend stand-alone work organizational interventions. However, such interventions could, in principle, enhance the effectiveness of physical ergonomics programs. The multidimensional interventions at the workplace can be recommended. However, if it's not possible to recommend which dimensions are important, which are the important content, and in what balance, what order should you have these multidimensional interventions. So there's a challenge. I also added a bulk on recommendations for further research. Generally, they need to be high quality. Where possible, that should be in form of randomized controlled trials. One should look at efficacy, effectiveness, and dissemination. And one should, in a future study, also include cost-benefit and risk-benefit analysis. I'll skip this. On the workers, good quality randomized controlled trials are needed to study effectiveness of daily physical activity for prevention of low back pain and for the recurrence of low back pain. In addition, the effectiveness of physical exercise as well as daily physical activity should be studied for prevention of sick leave due to low back pain. We need studies looking at the role of information oriented toward reducing fear avoidance that Johan talked about, beliefs, and improving coping strategies in the prevention of low back pain. And good quality RCTs are urgently needed to study the effectiveness of physical, psychosocial, and organizational ergonomic interventions on a large variety of outcomes. And we also need to know if the interventions could be applied to all workers. Are they gender-specific interventions? Are they age-specific interventions? Does it matter if you have a past history of low back pain? And we might get more and better preventive interventions. You will see that a lot on the back belts, back support, we do not need more research on that. It's not effective. The biomedical, biomechanical information, so we do not need more research on that either. It's not effective. Okay, I think I now hand over to Holger to answer the last question.